Welcome to Teaching Service Hospital Rounds. Today we cover colonic polyps and colorectal cancer screening. These two belong together in one lecture. Almost every colorectal cancer begins as a polyp. So if you understand how a polyp becomes a cancer, you understand exactly why we screen, why the intervals are what they are, and why removing a polyp is different from finding a cancer early. We will follow one patient from his very first colonoscopy through his pathology report, and build the biology, the polyp types, the screening menu, and the surveillance intervals around him. Pay attention to the numbers. They are the part residents get asked about most. Let us get started. Here is our patient. A 58-year-old man comes to clinic for a routine visit. He feels completely well. No abdominal pain, no rectal bleeding, no change in his bowel habits. His weight is stable. He works full-time and exercises rarely. And yet, he is the reason this lecture exists, because he has never had a screening colonoscopy. On the average risk rule, he should have started 13 years ago. And as you will see later, his family history makes him later still. So the whole visit turns on one question. What is silently growing in his colon right now? Keep him in mind. Every concept today comes back to him. Here is what you should take away. First, define what a polyp actually is, and separate neoplastic polyps from non-neoplastic ones. Second, trace the adenoma to carcinoma sequence from normal epithelium all the way to invasive cancer. Name the driver mutations at each step, and explain the serrated pathway, which is a second and entirely separate road to cancer. Third, recognize the risk and protective factors. Classify adenomas by histology, and define the term advanced-adenoma, because that one term drives management. And fourth, choose a screening test with the right interval, and apply post-polypectomy surveillance correctly. Those last two are where residents most often slip. Let us take the history properly. He denies abdominal pain. He denies nausea and vomiting. His stools are formed and daily. He has never seen blood in the toilet or on the tissue. He has had no unintentional weight loss, and his energy is normal. So the review of systems is completely unremarkable. And here is the teaching point. That is exactly what we expect. Most polyps produce no symptoms at all. A reassuring history does not lower his risk by a single percentage point. It simply means that if he has a polyp, only a colonoscopy is going to find it. Screening exists precisely because the history stays silent. Now the history that actually matters. His father was diagnosed with colon cancer at age 62, a first-degree relative. He smoked a pack a day for 20 years and quit at 45. His body mass index is 32, with most of the weight carried around the middle. He drinks about 6 beers a week. He was diagnosed with type 2 diabetes 4 years ago, and his diet is heavy in red meat and light on fiber. Every single one of those lines is a recognized risk factor for colonic polyps. Notice how ordinary they all sound. This is not an exotic history. We will come back and count them. The examination is reassuring. His abdomen is soft and non-tender. There is no palpable mass, no hepatomegaly, and no lymphadenopathy. The digital rectal exam finds no mass and no gross blood. His hemoglobin is 14.1 grams per deciliter, and his iron studies are normal. So there is no anemia to chase, and no occult bleeding to explain. Here is the point. A normal exam and a normal hemoglobin do not rule out a polyp, or even a cancer. Polyps bleed intermittently rather than continuously, so one normal hemoglobin proves very little. And nearly every polyp sits far out of reach of an examining finger. Let us define our terms carefully. A polyp is simply any tissue that protrudes from the mucosa into the lumen of the bowel. Notice what that definition does not say. It says nothing at all about what the tissue is made of. So polyp is a description, not a diagnosis. The endoscopist sees a bump and calls it a polyp. The pathologist then tells you what it actually is, and only then do you know what it means for the patient. That report determines whether he comes back in 10 years, in 3 years, or in 6 months. So never let a polyp go unlabeled in a chart or a handoff. The label is the whole point. Why do we care so much about polyps? Because the overwhelming majority of colorectal cancers begin as one. That single fact makes colorectal cancer unusual among cancers. In most cancers, we screen to find disease early, when it is small and still curable. In colorectal cancer, we screen to find and remove the precursor lesion, so that the cancer never forms at all. That is true prevention, not early detection. When you snare a polyp in the endoscopy suite, you may have just prevented a cancer that would have surfaced a decade later in that patient. Nothing else in cancer screening works quite like this. It is worth saying out loud to patients. Every polyp falls into one of two buckets. Neoplastic polyps carry a genetic program that can progress to cancer. That bucket holds adenomas, sessile serrated lesions, and frank carcinomas. Nonneoplastic polyps generally do not progress. That bucket holds hyperplastic polyps, juvenile polyps, Poitz-Jaeger's polyps, and inflammatory polyps. Sorting a polyp into the right bucket is the first thing you do with any pathology report. Because the neoplastic bucket drives surveillance, and the non-neoplastic bucket usually does not. But hold one exception in mind. Poytz-Jaeger's polyps can undergo malignant transformation. The wall is not perfectly solid. Now the biology. Colorectal cancer does not appear in one step. It is the accumulation of mutations in the DNA of colonic epithelial cells over many years. Those mutations hit two different families of genes. Oncogenes are the accelerators of cell division. A gain-of-function mutation jams that accelerator down. Tumor suppressor genes are the brakes. A loss-of-function mutation cuts the brake line. And here is the rule. Cancer requires both. You need the accelerator stuck on and the brakes gone. A single mutation is not enough, which is exactly why this takes years rather than weeks. Watch for that pattern as we walk the sequence. Follow the pathway across the screen. We start at normal colonic epithelium on the left. The first hit is loss of function in a gene called APC. That single event is what we call tumor initiation, and it produces an adenoma. Notice carefully that the adenoma is not a cancer. It is a benign neoplasm that has taken the first step. Then comes tumor progression along the second arrow. K-ras gains function. DCC is lost, and P53 is lost. With those hits accumulated, the adenoma becomes a carcinoma. So the model is one initiation event, followed by a series of progression events. Each arrow takes years, and that is the window screening lives in. Let us slow down on the first step. APC stands for adenomatous polyposis coli. It is a tumor suppressor gene, and it is often called the gatekeeper of the colon. When both copies are lost, crypt cells stop obeying the signals that tell them to stop dividing. The crypt architecture is disturbed, and an adenoma forms. This is why APC loss is called tumor initiation. It opens the gate that everything else walks through. And here is the clinical bridge. When a patient inherits one defective copy of APC in the germline, every cell in the colon is already halfway there, and they develop familial adenomatous polyposis, hundreds to thousands of adenomas. Now the progression steps. K-ras is an oncogene. It gains function, and that is the stuck accelerator we talked about. It drives relentless proliferation of the adenoma. DCC is a tumor suppressor on chromosome 18, and its loss removes another brake from the system. And P53 is the guardian of the genome. Normally it halts a damaged cell at a checkpoint, or forces it to die. When P53 is lost, cells carrying piled-up mutations survive and keep dividing. That is usually the late event in the sequence, and it is the one most closely tied to the change from adenoma to invasive carcinoma. Here is why all of that biology matters clinically. The sequence is slow. It generally takes on the order of 10 years for an adenoma to become an invasive carcinoma. That decade is a completely silent window. The patient feels nothing, but the lesion is sitting there quietly accumulating mutations. And that window is exactly what screening exploits. If you find and remove the adenoma anywhere along the way, the sequence stops. There is no cancer at the end of it. So the 10-year screening interval is not an arbitrary number. It is deliberately built to fit inside the natural history of the disease. Shorter intervals are used when the biology runs faster. There is a second road to colorectal cancer, and it does not use APC at all. Follow the lower lane. It begins with a mutation in a gene called BRAF. That produces a sessile serrated lesion rather than a conventional adenoma. Then widespread methylation of gene promoters silences genes without ever mutating them. When the mismatch repair gene MLH1 is silenced this way, the cell loses its ability to fix replication errors, and you get a microsatellite unstable cancer. Why does this matter at the bedside? Because these lesions are flat, pale, right-sided, and genuinely easy to miss on colonoscopy. A different biology, and a different look. Now the risk factors? Start with the ones the patient cannot change. Age is the dominant one. Polyp prevalence climbs steadily with each decade of life. Family history matters, particularly colorectal cancer in a first-degree relative, and it matters more when that relative was young at diagnosis. Two inherited syndromes carry very high risk: Lynch syndrome and familial adenomatous polyposis. And inflammatory bowel disease raises risk, both ulcerative colitis and Crohn's colitis, through years of chronic mucosal inflammation and repair. Notice that our patient already owns two of these: his age and his father's diagnosis. Neither is negotiable. Now the modifiable list. A diet high in fat raises risk. Central adiposity raises risk. And note carefully that the distribution of the weight matters, not only the number on the scale. Increased alcohol intake raises risk. Low fiber intake raises risk. High red meat consumption raises risk. Smoking raises risk. And that risk persists for years after quitting. And diabetes mellitus raises risk independently of body weight. Run that list against our patient. He is a former smoker. He is centrally obese. He drinks regularly. He is diabetic. And he eats red meat with very little fiber. He carries every item on this slide. Two syndromes deserve their own moment. Lynch syndrome comes from germline defects in the mismatch repair genes. Patients do not grow hundreds of polyps. They grow only a few. But each one progresses unusually fast, and the cancers tend to be right-sided and to appear at a young age. Lynch also carries risk beyond the colon. Endometrial cancer in particular. Familial adenomatous polyposis comes from a germline APC mutation, the same gatekeeper we discussed. Here the colon carpets with adenomas beginning in adolescence, and without colectomy, the lifetime risk of colorectal cancer approaches 100%. Both need genetic counseling. Now the other direction. What actually protects against polyps? Increased physical activity protects. Aspirin and other non-steroidal anti-inflammatory drugs protect. Calcium intake protects. Hormone replacement therapy is associated with lower risk, and a lower body mass index protects. Then there is a second tier where the evidence is softer but suggestive. Increased fiber, vitamin D, fish oil, statins, and selenium. Be honest with patients about that difference. The first column is established. The second column is possible. Do not oversell the supplements, and do not start aspirin for this reason alone without weighing bleeding risk. Let us total him up. He is 58, risk factor 1. His father had colorectal cancer at 62. 2. He is a former smoker. 3. His body mass index is 32, with central adiposity. 4 and 5. He drinks regularly. 6. He is diabetic. 7. And his diet is high in red meat and low in fiber. 8. Now the protective side. He is sedentary. He takes no aspirin, and he has no meaningful calcium intake, so the protective column is empty. This is a man stacked heavily on one side of the ledger. His pretest probability of polyps today is high. Expect the colonoscopy to be abnormal. Let us open the neoplastic bucket. There are 3 classes inside it. First, adenomas. These are the classic precursor lesions, and they come in 3 histologic patterns: tubular, tubulovillous, and villous, all of which carry dysplasia by definition. Second, sessile serrated adenomas, also called sessile serrated polyps. These travel the serrated pathway we just drew, and they are the lesions most strongly associated with interval colorectal cancer. Third, carcinomas, meaning a polyp that already contains invasive cancer, and that one changes the conversation from surveillance to staging and treatment. Adenomas are graded by their architecture. Tubular adenomas are the most common. They are built of rounded branching tubular glands, and they carry the lowest malignant potential of the 3. Tubulovillous adenomas are a mixture of both patterns, and they sit at intermediate risk. Villous adenomas are built of long finger-like fronds, and they carry the highest malignant potential. They also tend to be larger at diagnosis. One rule to hold on to: every adenoma contains dysplasia by definition. There is no such thing as an adenoma without dysplasia. The only question the pathologist answers is how much, low grade or high grade. Look at the 3 panels. On the left is a tubular adenoma. Notice the rounded branching glands packed closely together. That is the tubular pattern. In the middle is a tubulovillous adenoma, and you can see both rounded glands and elongated projections coexisting in the same lesion. On the right is a villous adenoma. Those long finger-like fronds reaching up into the lumen are the villi that give the lesion its name. Now follow the arrow along the bottom. Malignant potential rises steadily from left to right. So architecture is not a cosmetic detail on a report. It predicts behavior, and it changes the interval. Here is a term you must own. An advanced adenoma is any adenoma that meets at least one of 3 criteria. It measures 10 millimeters or larger, or it contains a villous component, or it contains high-grade dysplasia. Any one of the 3 alone is enough. You do not need all 3. Why does this matter so much? Because advanced adenoma is the threshold that separates a patient who comes back in 7 to 10 years from one who comes back in 3. When you read a pathology report, look for those 3 features first, before anything else on the page. They decide the interval, and a wrong interval is how patients get lost. Sessile serrated lesions deserve real respect. They are flat rather than raised. They are pale, often exactly the color of the surrounding mucosa. They sit predominantly in the right colon, and they are frequently covered by a cap of mucus with indistinct borders. Add all of that together, and you get a lesion that is genuinely hard to see, even for an experienced endoscopist. That is why they are the leading contributor to interval colorectal cancer, meaning a cancer that appears between one colonoscopy and the next scheduled one. In most of those cases, the lesion was there at the first exam. It was simply not seen. Now the nonneoplastic bucket, starting with its most common member, the hyperplastic polyp. These are typically small, usually under 5 millimeters, and they sit in the distal colon and the rectum. Under the microscope, they have a sawtooth or serrated appearance, which is exactly why they can be confused with sessile serrated lesions. The crucial difference is dysplasia. Hyperplastic polyps do not have it. Small distal hyperplastic polyps do not raise a patient's cancer risk, and they do not shorten the screening interval at all, so do not overmanage them. A patient whose only finding is 3 small rectal hyperplastic polyps still returns in 10 years. 3 more sit in this bucket. Juvenile polyps are hamartomas. They are the most common polyp in children, and usually present with painless rectal bleeding. A solitary juvenile polyp is benign, but juvenile polyposis syndrome is a different matter entirely, and does carry cancer risk. Poitz-Jaeger's polyps are also hamartomas, paired with dark pigmented spots on the lips and the buccal mucosa, and here's the exception to remember. These can undergo malignant transformation. And inflammatory polyps, also called pseudopolyps, are islands of regenerating mucosa left behind by inflammatory bowel disease. They carry no malignant potential themselves. Take a moment with this table. Read down the bucket column first. The top 4 rows are neoplastic. The bottom 4 are not. Now read across to the risk column. Villous adenomas and sessile serrated lesions carry the highest risk. Tubular adenomas are the lowest among the adenomas, and small distal hyperplastic polyps and inflammatory pseudopolyps carry essentially none. And notice the one line that crosses the wall between the buckets. Poitz-Jaeger's, a hamartoma that can still transform. If you can reconstruct this table from memory on rounds, you can interpret almost any colonoscopy pathology report you are handed. How do polyps present? The honest answer is that most of them do not present at all. They are silent and found only on screening. When they do speak, the most common voice is occult bleeding that shows up as iron deficiency anemia. In an adult with iron deficiency and no other explanation, the colon must be examined. That is a rule and not a suggestion. Some polyps bleed visibly as hematochezia. A large villous adenoma can secrete enough fluid and potassium to produce a watery secretory diarrhea with hypokalemia, and a very large polyp can obstruct or act as the lead point of an intussusception, though both of those are uncommon. Now we turn to screening. The purpose is the one we established earlier. Interrupt the adenoma to carcinoma sequence before it finishes. For average risk patients, screening begins at age 45, and it typically repeats every 10 years as long as nothing abnormal is found. That start age was lowered from 50 because colorectal cancer has been rising in younger adults. So if you trained a few years ago, update the number in your head. Look back at our patient. He is 58 and has never been screened at all. Getting him scoped is the single most important thing we do at this visit. Everything else is secondary. Here is the entire menu on one slide. Colonoscopy is the gold standard and repeats every 10 years. Flexible sigmoidoscopy repeats every 5 years, or every 10 years, if you pair it with a fecal immunochemical test every single year. CT colonography repeats every 5 years. On the stool side, fecal occult blood testing or the fecal immunochemical test is done yearly. Fecal DNA testing, marketed as Cologuard, is done every 3 years. And blood-based DNA tests are emerging but are not yet a primary strategy. Notice the pattern down the interval column. The less sensitive the test, the more often you repeat it. Let us take the stool tests in turn. Fecal occult blood testing and the fecal immunochemical test are both done yearly. The immunochemical test detects human globin specifically, so it does not react to dietary meat or to peroxidase-containing vegetables, and it needs no dietary restriction at all, which is why it has largely replaced the older Guaiac test. Fecal DNA testing combines DNA markers with an immunochemical test and repeats every 3 years. Now the rule that gets forgotten on wards. Any positive stool test must be followed by a colonoscopy. A positive result is not a diagnosis, and it is never repeated to see if it clears. Now the structural alternatives to colonoscopy. Flexible sigmoidoscopy examines the left colon only. It repeats every 5 years, or every 10 years, when it is combined with a yearly fecal immunochemical test. Its blind spot is the right colon, which is precisely where sessile serrated lesions live, so it is a compromise and you should name it as one. CT colonography repeats every 5 years and images the whole colon, but it cannot biopsy or remove anything, and it turns up incidental findings outside the colon that then need their own workup. Both of these share the same rule. Anything abnormal leads straight to a colonoscopy. And now the gold standard. Colonoscopy examines the entire colon from the rectum all the way to the cecum. It is the only screening test that is also a treatment. You find the polyp, and you take it out in the same session, under the same sedation. Every other test on the menu, if it is positive, simply earns the patient a colonoscopy anyway. So the question is rarely whether a colonoscopy will happen, only when. For an average risk patient with a normal complete examination and adequate preparation, the interval is 10 years. That interval is long, precisely because the test is thorough and the sequence is slow. Not all colonoscopies are equal, and residents should know the quality metrics that separate them. The adenoma detection rate is the proportion of screening examinations in which at least one adenoma is found. A higher detection rate is associated with fewer interval cancers, and that association is strong. Cecal intubation must be documented, otherwise you do not actually know the right colon was examined. Withdrawal time should be at least 6 minutes, because withdrawal is when lesions are actually found, and the bowel preparation must be adequate. If the prep is poor, the exam does not buy 10 years. It has to be repeated sooner. Now the higher risk groups, starting with family history. If a patient has a positive family history of colorectal cancer, screening begins at age 40, or 10 years before the age at which the youngest affected family member was diagnosed, whichever of those comes first. And the interval shortens from 10 years to 5. Now apply that to our patient. His father was diagnosed at 62, 10 years before that is 52, and age 40 is earlier still, so 40 is the answer. He should have begun at 40. So he is not 13 years late, as we said at the start. He is 18 years late. Always run this rule before quoting a start age. 3 groups need a different schedule entirely. In inflammatory bowel disease involving the colon, surveillance generally begins about 8 years after disease onset, and then repeats every 1 to 3 years with biopsies taken specifically to look for dysplasia. In Lynch syndrome, colonoscopy begins in the early 20s and repeats every 1 to 2 years, because those few adenomas progress so quickly that a longer interval is unsafe. In familial adenomatous polyposis, endoscopic surveillance begins in early adolescence and repeats yearly, with colectomy planned rather than avoided. All 3 of these patients belong with a gastroenterologist. Once you remove a polyp, the 10-year clock no longer applies automatically. The interval is set by what the pathology showed. A completely normal colonoscopy returns in 10 years. Small distal hyperplastic polyps also return in 10 years. They do not shorten anything. 1 or 2 tubular adenomas smaller than 10 millimeters return in 7 to 10 years. 3 or 4 tubular adenomas under 10 millimeters return in 3 to 5 years. Notice the logic running through the whole table. More adenomas, or larger adenomas, or worse histology, means a shorter leash. Count them and measure them before you quote an interval. Now the higher risk findings. Any advanced adenoma, meaning 10 millimeters or larger, or villous, or carrying high-grade dysplasia, returns in 3 years. 5 to 10 adenomas also returns in 3 years. More than 10 adenomas returns in 1 year, and that patient should additionally be evaluated for a polyposis syndrome. And the shortest interval of all, when a lesion 20 millimeters or larger was removed piecemeal rather than in one piece. The scar is re-examined in 6 months, because piecemeal removal leaves residual tissue behind more often than we would like. That 6-month look is a recheck of the site, not a full surveillance exam. The pitfalls that cost patients. First, unexplained iron deficiency anemia in an adult means the colon gets examined, every time, no exceptions. Second, a positive stool test earns a colonoscopy, never a repeat stool test. Third, a colonoscopy done with poor preparation is not a 10-year examination. Bring the patient back rather than pretending it counted. Fourth, flat right-sided serrated lesions are the ones that get missed, so look deliberately for the mucus cap and the subtle border change. And fifth, never accept a report that says polyp removed without telling you what it was. The histology is what sets the interval. Back to our patient. He had his colonoscopy. The preparation was excellent, and the cecum was reached and photographed. 4 kinds of lesion came back on the pathology report. A 12 millimeter tubulovillous adenoma in the sigmoid colon. 2 tubular adenomas in the descending colon, both under 10 millimeters. 1 flat sessile serrated lesion of 8 millimeters in the ascending colon. And 3 small hyperplastic polyps in the rectum. All of them were removed completely and in one piece. Now work the report the way we just practiced. Which single finding sets his surveillance interval? Take a second before we answer. Here is the answer. The 12 millimeter tubulovillous adenoma is the finding that drives everything. It is 10 millimeters or larger, and it also has a villous component. Either one of those features alone would already make it an advanced adenoma. So his surveillance colonoscopy is at 3 years, not at 10. The 2 small tubular adenomas and the sessile serrated lesiondo not lengthen or shorten that interval, and the hyperplastic polyps change nothing at all. Alongside the scope, we counsel him. Weight loss, physical activity, more fiber, less red meat, less alcohol, and we tighten up his diabetes control. Let us bring it all together. A polyp is a description. The histology is the diagnosis. Loss of APC initiates the adenoma, and K-ras, DCC and P53 drive it onto carcinoma over roughly a decade. The serrated pathway is a separate road running through BRAF and gene silencing, and it produces the flat right-sided lesions we miss. An advanced adenoma is 10 millimeters or larger, villous, or high-grade dysplasia, and it shortens surveillance to 3 years. Screening starts at 45 for average risk, and at 40 when there is a family history. Find the polyp, and you have prevented the cancer. These are the sources behind today's material. The molecular model of colorectal carcinogenesis follows the New England Journal Review of Colorectal Cancer Pathogenesis. The screening menu and the start age of 45 follow the current JAMA screening review and the United States Preventative Services Task Force recommendation. And the post-polypectomy surveillance intervals follow the United States Multi-Society Task Force on Colorectal Cancer. Thanks for working through this one. Remember the sentence that holds the whole topic together. Find the polyp, remove the polyp, and you have prevented a cancer. See you on the next topic.